Um, Good afternoon, everyone. Good afternoon to our esteemed guest, Professor Uchenna Okonkwo. We are very glad to have you in this month's webinar of Redus Center for Digestive Health. Today, we have the pleasure of having Professor Okonkwo discuss hepatitis, breaking it down to simple terms that all of us can understand. Just to read a short, very brief resume of Prof. Professor Okonkwo is a fellow of both the West African and National Postgraduate Medical College. She is an esteemed researcher and a reviewer of so many journals. His area of interest and specialty is in gastroenterology, hepatology, and also in the field of inflammatory bowel disease. She's a professor at the Nnamdi University, Teaching Hospital, Nnewi. He has a lot of interest in viral hepatitis, hepatocellular carcinoma, functional bowel disorder, and other related health areas. It's our pleasure to have her today lead us in the discussion on this very important topic on hepatitis. As we all know, this is hepatitis month, and a lot of awareness is on this topic to help people understand, from the etiology, the risk factors, the preventive strategies, and the current things as it pertains to management of people with hepatitis. It's my pleasure to introduce Professor Okonkwo to lead this discussion today. Prof, thank you so much for being here. Over to you, ma'am.
Thank you. Thank you very much, Dr. Lassie, for that introduction. And thank you, management of Redus, led by Dr. Kene, for having me. So if you don't mind, Dr. Eva, you can move on the slide. The theme for this year's World Hepatitis Day, it's hepatitis. Let's break it down. Since 2010, the World Health Organization adopted July 28 as a day to create awareness for hepatitis B and C, because it's become a major global problem worldwide, especially in this part of the world, as we're going to see in the course of the presentation. The day, 28th July, was chosen to honor the scientist that discovered this virus, Dr. Baruch Lundberg. And so the aim of the campaign, like was said, is to create awareness amongst communities, encourage governments, healthcare providers to escalate preventive measures, treatment measures, in the hope to eliminate this deadly virus from our community. Thank you. Can you, the next slide, please? And so the highlights of the campaign, just like we're doing, is to raise awareness. This discussion is to educate and to share, hopefully, what happens in our own side of the world where we practice. To reduce stigmatization, I remember when I started this practice about 15 years ago, I mean, it's almost, people feel very stigmatized.
Hello, Eva. Can you still hear Prof?
No, I think
Okay.
from our end.
Yes. Prof, if you can hear us, we've lost the connection to you for the past 5 seconds or so. I think we'll just wait for her to connect back in the audio.
Hello, am I back on?
Yes,
Yes,
you're back.
we hear you now. We lost you for
Sorry,
about 15
please.
seconds. Yes, ma'am.
Sorry, please. Can we go ahead?
Yes.
Okay.
Yeah, Prof, go ahead. Go ahead.
The next slide, please. Yeah, so can I move on to the next slide?
Yes,
So what is
go on, please.
hepatitis? As we all know, hepatitis is inflammation of the liver parenchyma, mostly caused by viruses, but there are other causes, including bacteria, alcohol, medications, some autoimmune diseases. The liver is a very important organ in the body, and dysfunction of the liver leads to myriad of problems. Some of them are life-threatening. Can we move on? And so there are 5 major viruses, A, B, C, D, E. This discussion, we're just going to zero in on the hepatotrophic viruses. We won't bother with other causes of viral hepatitis. And of all the 5 viruses, there are a few not so common ones, which we're not going to talk about. B and C and D, in the presence of B, causes chronic hepatitis, and they are the ones that are of much public health concern. A and E generally causes acute hepatitis that are self-limiting in most of the cases. Can we move on, please? So the burden of hepatitis B virus, according to the WHO, hepatitis B affects 2.9% of the global population, which is about 240 to 254 million persons. And the highest regional burdens are in West Pacific and the in sub-Saharan Africa. The Western Pacific regions include countries like China, Japan, Malaysia, Indonesia, and all that. And for sub-Saharan Africa, Nigeria is a key country in that region. Approximately 0.9 million new chronic infections occur per year, with the African region accounting for more than 1/3 of these new infections. The global prevalence in under 5 children is on the decline. Except in the African region, only 5% of persons eligible for hepatitis B virus treatment are receiving that treatment. You could see that's a major concern. 1.1 million deaths occur annually from chronic hepatitis B virus, mostly from chronic complications like liver cirrhosis and liver cancer, and 3/4 of those deaths occur in sub-Saharan, in the African region, the WHO African region. Please, the next slide. So still on the regional burden of HB infection, like we said, the Western Pacific region accounts for most of this infection. But the good thing about it is that the incidence of new infection in this region is on the increase. Unlike the African region that accounts for the second highest number of persons living with chronic hepatitis, both B and C really, the incidence of new infection is on the increase. Can we move on, please? So a little bit of the national burden. In the sub-Saharan African region, Nigeria has the highest burden of hepatitis B virus infection, with a prevalence of 5.4%, according to the 2022 data. Before now, the prevalence of hepatitis B in Nigeria has always been in the range of 8.1 to 12%. And so I should think the decline in terms of the number of persons living with chronic hepatitis. There is a kind of inequality in the distribution of this virus in terms of regional affectation, gender, and residential area. Persons in northern Nigeria have more of this virus compared to persons in southern part of the country. The male gender, it's more disproportionately affected. And rural dwellers are also more disproportionately affected compared to urban dwellers. Now, the prevalence of occult hepatitis infection, it's quite high in the environment, though we don't really talk much about this. And only about 10% of persons eligible for treatment for hepatitis B are able to access care currently. Can we go ahead, please? Hepatitis C, globally the prevalence is decreasing, accounting for about 47 million persons are thought to be currently living with chronic hepatitis C virus infection, according to the latest WHO data. The Eastern Mediterranean region, and again the African region, has the highest prevalence, although this time it's more of northern countries in northern parts of Africa that are more affected. There is a declining incidence of new HCV infection and mortality of about 8% and 12% respectively. And this could be improved on because as of the current data, only about 20% of people eligible for HCV infection are currently receiving it. So there's a large pool of persons who should be treated that are still unable to access care for this infection, which is now curable. What are the risk factors for hepatitis B and C infection? Good enough, both of them share the same risk factors. And the most common is contact with infected blood, whether it's semen, vaginal fluid, saliva inclusive, unsafe injections, unsafe blood transfusions, sharing of shafts, scarification, using non-sterile tools for equipment for scarification and tattooing. I really wanted to point out this communal use of toothbrush. It seems to be a problem with rural dwellers in Nigeria. Most of the studies have pointed to this particular risk as common means of transmission, horizontal transmission in rural communities in Nigeria and some other African countries. Sexual transmission is an important route of transmission, but the good thing about sexual transmission is that it should occur in adults, definitely not in children. And most people who acquire this virus as adults, especially hepatitis B, only about 5% of them go on to develop chronic infection. So that for us, mother-to-child transmission, either via vertical transmission, horizontal transmission in under 5s, remain the most common route of transmission. Occupational exposure for healthcare workers, especially, is also a significant means of transmission. Factors that accelerate disease progression. We know that for hepatitis B and C, most people with this infection do not know they have it. People have this infection for many years, remaining asymptomatic until they develop symptoms related to liver dysfunction, not necessarily related to the virus, before they realize for the first time that they have the virus. But then the number of years someone could have this dormant infection depends on a lot of factors. And some of these factors include viral factors, the DNA levels, the HBe antigen status of the virus, of the person who has the infection, the viral genotypes and mutations. Genotype E is the most prevalent in Nigeria. However, genotype C and D are more commonly associated with rapid progression and more severe infection. Co-infections with hepatitis C virus, HIV, and HDV could also accelerate disease progression in persons with chronic hepatitis B infection. Then host factors like the age, the older the person, the more they are likely to develop liver dysfunction from this virus. Males have been shown to have disproportionate affectation in terms of liver cirrhosis, HCC, compared to females. Immune status of the patient, those who have diabetes, those on long-term steroid use, immunosuppressive medication, including cytotoxics, are more likely to develop more rapid disease progression than those without this condition. Environmental factors, especially alcohol abuse, aflatoxin, and recently metabolic syndrome, metabolic associated fatty liver disease dysfunction has been shown to accelerate progression of underlying hepatitis B or C virus infection. Yes, please, can I? So how do we make a diagnosis? Diagnosis is pretty simple. Simple serological tests like the surface antigen screening, which is the commonest screening we do. It's available both in rural communities and primary healthcare centers, and for hepatitis C, the anti-HCV antibody screening. The hepatitis B core antibody assay we don't routinely do in our environment, but I think in developed countries, it's something that is routinely done. I've seen some reports from there. Before, anytime you go to do your surface antigen screening, the core antibody assay is attached to the screening, which we don't routinely do. And I think it's affecting part of it's really one of the challenges we have in curbing this infection, especially in terms of blood transfusion. We're going to talk more about that. Then the other things, once the screening tests are positive, the next thing is to assay, quantify the virus, the HBV DNA for hepatitis B, and the HCV RNA for hepatitis C. Liver function tests, especially ALT levels, is very important. Ultrasound, yes, is also important. Transient elastography, while it's important, even though it's not very much available around here, but it's something that can help if it's available. And then liver biopsy, even though again, it's no longer popular, even in our own practice, and really not usually indicated as a means of diagnosis for chronic hepatitis. But I just included it here, but in certain scenarios, it may still be important to biopsy the patient. Can we go ahead, please? And so based on the WHO, the expanded treatment guidelines for chronic hepatitis B, what are the indications for treatment? Previously, the indications for treatment or the recommendations used to be quite stringent. But recently, with the target year for elimination of viral hepatitis fast approaching, that is 2030, the WHO has tried to make the guidelines more flexible with the hope of accommodating more persons with this virus, making it possible for them to access care. So now the recommendation states that all persons with hepatitis B virus DNA greater than 2,000 as opposed to 20,000 international units previously, and any elevation of ALT above the upper limit of normal, irrespective of the E antigen status, should be started on antiviral medications. Persons with significant fibrosis using their pre-score of greater than 0.5 or fibroscan parameters of 7 kilopascals above that, again, irrespective of HBV DNA and ALT levels, should be started on treatment. Although for us down here, a recent study suggested that even for Africans, that an APRI score of 0.45 should actually be considered for significant fibrosis. Again, the margin is close to 0.5, so maybe it doesn't make much difference. All persons with a positive family history of liver cancer or cirrhosis that are surface antigen positive, irrespective of their ALT or DNA levels, should be accorded treatment. Then persons with co-infections, whether it's HIV, HCV, HDV, persons on long-term immunosuppressive medications, cytotoxic therapy, transplant patients, and recently persons with comorbidities, DM, MAFLD, should be accorded treatment. Now, persons with extrahepatic manifestations should be accorded treatment irrespective of their viral status, whether it's renal involvement, skin involvement, whatever involvement. Then persons with persistently abnormal ALT levels irrespective of DNA levels, should also be commenced on treatment. Can we move on, please? For hepatitis C virus, treatment is very simple and straightforward. Once anybody has the antibody, which signifies a previous exposure, any detectable HCV RNA should be started on treatment. And treatment is usually an 8 to 12-week course of directly acting antivirals. The aim is to cure, to achieve sustained virological response at least 6 months after therapy, and that signifies cure for this virus. Can we go ahead, please? Now, preventive strategies. Hepatitis B virus is preventable, and vaccination is the key to prevention. A few years ago, I think sometime, maybe 10 years ago, not really that few, 2020, 2016, we did a brief survey of traders somewhere in southern part of Nigeria. And it was amazing how very little people knew about hepatitis and that there are vaccinations even for adults. There are vaccines for adults, there are vaccines for children, which is now part of the expanded program on immunization protocol for Nigeria and for most other countries. So vaccination is preventive. Once someone completes the 3 doses of the vaccine, prevention is mostly lifelong and there's no need for booster vaccination for most patients. Safe sexual practices, use of condoms, that cannot be overemphasized. Then safe blood and blood product transfusion practices. Like I mentioned earlier, the prevalence of occult hepatitis B infection in Nigeria, it's quite significant. And for most of our blood bank services, it's only the surface antigen that is screened, not the core antibody. And so there is still a slight risk that we may be transmitting this virus inadvertently to persons, especially children who receive blood transfusion. And so the campaign has always been, we have been at the forefront, so going to encourage the Ministry of Health in Nigeria and other persons involved in policy making to make the core antibody a key parameter to assay, especially amongst blood donors. Now, personal grooming material should be kept personal because there's risks, especially even within family members, amongst friends. Safe injection practices. In our own environment, we've also found that intramuscular injections, it's a risk. It's not just the intravenous injections. And so we have been advocating that, especially mothers, some mothers will tell you, give injections. They have this idea that injections are more effective than oral medications. And then it could be a risk of transmission of this virus to these children. So injections, whether IM intravenous, should be when it's essentially necessary to give them. And then the universal precautionary measures must be adhered to. Now, on prevention of mother-to-child transmission, a lot is being done under the subheading. A lot more pregnant women are being screened, but again, in rural population where most women will rather deliver at home, that is still a problem. Pregnant women don't get to access this care. But where they are being assessed, women are being screened, and the regulation is that once a woman is positive, again, irrespective of the viral load, in the second trimester, they should be started on antiviral therapy, and this is to prevent transmission of this virus to the child through the end of pregnancy, through breastfeeding, and then continued if they have a clear indication to continue treatment based on their own safety. It's also advocated that children should at least get the birth dose of this vaccine within 24 hours of birth. Now, that practice, studies have shown, it's not still, the uptake of the birth dose of hepatitis B vaccine is still low in our country. And the challenges are, again, more in rural centers, persons who deliver at home, or in traditional birth homes where these services are not available, or maybe just be ignorant of the availability of this service. So the birth dose given within 24 hours is really what is advocated, that they get the birth dose of the hepatitis B vaccine. And if it's possible to follow it up with the immunoglobulin, that is fine. That increases the chances of, preventing vertical transmission. But even when they can't do that, I think the birth dose adds some significant protection to the neonates, because the immunoglobulin is still expensive in this part of the world, and persons will have to pay out of pocket for it. Let's move on, please. But I also think that our colleagues in O&G are doing a lot better in terms of screening the pregnant women for hepatitis. I interacted with some primary healthcare workers around here sometime, and they do a lot of screening too for the pregnant women. The challenge is what they do afterwards. If they link them up to care, if they know they should be started on antiviral therapy, because irrespective of those things, or despite those things, most clinicians still refer the patients to the tertiary healthcare center to start care. And those who are unable to get to the tertiary healthcare center may still not be able to start care. And there have been scenarios where, because persons are asymptomatic, they are fine, even healthcare providers give them the false impression that they are safe and that they shouldn't bother. I mean, there's nothing wrong with them. And that is still a bit of a problem. And so in summary, hepatitis B and C virus, they still remain a huge public health problem, especially in Nigeria. I think I want to drive it home. It's again in the African sub-region generally. But in Nigeria, like we said, Nigeria has the highest burden, even in the African sub-region. Although the national prevalence is showing a downward trend, which I will have to congratulate the professionals in this field. Like I said, when I joined the gastro subspecialty in this part of the globe, there's nothing like chronic hepatitis. Everybody that comes into the clinic comes in with one or the other form of chronic complication. You barely find them persons at the stage of chronic hepatitis coming in. And so we appreciate the work being done, but a lot still needs to be done. And I think I've tried to highlight some of the challenges that we have in getting to the 2030 target of 0.1% prevalence. Majority of persons with hepatitis B virus infection are still not receiving antiviral medication. Out-of-pocket payment is still a problem. There was a time it was advocated that persons with hepatitis B should, be linked to care with persons with HIV so they could access the free medication. Unfortunately, the single tenofovir, which is what you use for persons with hepatitis B is not included in the free medications. And then people were worried taking the same medications for HIV. They felt even more stigmatized. And that hasn't really been achieved. And so most people with chronic hepatitis B, C, they pay out of pocket for the medication, and the healthcare cost is considerable. For B, because of the long-term nature of the medication, and for C, even though short-term is curative, it is still quite expensive. Even for generic medications, it could cost close to 400, 500,000 to get a proper treatment for hepatitis C virus infection. And so these persons who are infected and are not accessing care continue to form infectious pool for new infections to occur. The birth dose of HPV vaccine, the uptake is still very low. And so vertical transmission, horizontal transmission amongst children, which is really the key problem where you have hyperendemicity of this problem, because children get infected, 90% of them progress to chronic hepatitis and they remain asymptomatic for a very long time. Hepatitis B virus is preventable. It is vaccine preventable. Everybody should screen and get vaccinated. Thank you very much.
Thank you so much.
Thank you. These are the references, just a few of them, and thank you.
Thank you so much, Professor Okonkwo, our teacher, for this master class. I wasn't expecting less. I used to tell Dr. Eva that in those days as medical students, when we want to get too much stuff, we'll come for Dr. Okonkwo in those days, we'll come for our word round, and we say you get impregnated with stuff. So thank you so much, Ma, for this very excellent presentation on hepatitis. I'm going to leave the rest of the anchorage to Dr. Eva to facilitate the Q&A session. Eva, over to you.
Thank you so much, Dr. Lassie. Thank you, Professor Okonkwo. It's like today is like listening to the mentor. Sitting under the mentor, just like the class said, we couldn't have expected anything less from one who has done a lot of work in this field. Prof, we just want to get to ask some questions, and our participants are also here, and some of them will be asking questions. Please, if you have questions, I can type it on the chat so that we look at them. But let's start with these questions. Prof, when you were presenting, you talked about these are practice we have now where blood transfusion we just create hepatitis. Most places they screen hepatitis, they just look for hepatitis B surface antigen and then and transfuse patients just because hepatitis B something came out negative. And the challenge we have is that if we transfuse the same blood that it has occurred hepatitis to people who are immunosuppressed, the likelihood that they now develop hepatitis B is high. So the question now, what will be your take? Should SOGIN or the national policy be strengthened to call for screening of all patients with all blood we're going to transfuse with complete panel, or should we still continue with what we're doing now? What is your take on that?
Thank you very much, Dr. Eva, for that question. I think this has come up a few times during the SOGIN conference, and the take has always been to sensitize SOGIN bodies, blood bank, people involved in blood transfusion. It is imperative that the core antibody assay, even if not the whole panel test, but you must screen surface antigen, you screen for the core antibody, should be incorporated as part of the screening for persons before blood transfusion. Otherwise, the risk still remains that people could get infected from blood transfusion even when apparently proper screening was done.
Thank you. Another question, is it true that one can contract hepatitis infection for years without even knowing that this infection if one has contracted infection?
Yes, very, very true. And that's part of why that is mainly the reason why it's very dangerous, both for hepatitis B and C, but especially for hepatitis B. Children get this infection during birth from their mother or as children under 5, and they live with this virus for many years until probably in their late teenage years or early adulthood, they begin to develop symptoms related to liver dysfunction. So they have no symptoms until the liver begins to fail. And that is why we find hepatocellular carcinoma in very young persons in this part of the world. In the European countries, you find HCC persons in the 6th decade of life, 7th. But here you find HCC in persons in the 3rd and 4th decade of life, sometimes in the 2nd decade. And it's all because of getting this virus very early in life and living with it for several years without it manifesting at all in any way. until the liver begins to fail.
Thank you. Another question is, some people will ask you, when you are telling me to go for treatment, are you going to cure me of hepatitis B? If you cannot cure me, what exactly do you want? Why are you asking me to go and start treatment? If you say there is no cure at this time, so Chief, what would you tell what should be how should we address those people that come up with this kind of argument for not going for treatment?
Well, that has always been a challenge to us in this practice, but we try as much as possible to tell patients the truth, because patients go on the web and they see all sorts, of things that says cure promises, all kinds of cure. We tell them, yes, for acute hepatitis, they don't need to take anything. It's self-limiting, they get cured. But once it has gone into chronic hepatitis, that the aim of treatment is to keep them safe. Treatment inactivates the virus and makes it very difficult for the virus to harm them in any way. So they have to be on long-term treatment so that the virus will continue to remain suppressed. However, if they meet the criteria for functional cure, which is surface antigen loss, then we can take them off treatment, but they must remain on lifelong monitoring. I've seen a few patients, one particularly comes to mind, who got his treatment in those days in the US with interferon. He developed surface antigen loss and all that and stopped treatment. 10 years down the line, he had come back to Nigeria. He presented for the first time with metastatic liver disease, with spinal affectation. That was his first presentation. And so when he told the story, what happened was that at the point he got the functional cure, he stopped monitoring. He stopped, going on surveillance. And then there's still a problem. And we all know that, the professionals know that, because the virus remains in a form known as the covalently closed DNA somewhere in the liver, even though it's inactive, but you wouldn't know. Certain situations, immunosuppression, whatever could happen, and then it begins to replicate again and becomes dangerous. So the key for persons with chronic hepatitis is that the virus makes them safe. It inactivates the virus, makes it unable to harm them in any way. That is one. And even when for any reason, they stop the treatment, even if they have achieved surface antigen loss, that is important that they remain under surveillance for reactivation and possible development of complications, liver cirrhosis or HCC.
Thank you. What would be your advice to people who are waiting for symptoms to occur before, when you say go and screen yourself, they tell you they don't have any symptoms? What would be the danger of waiting for symptoms before one goes to screen for hepatitis B or viral hepatitis in general?
Well, that is very dangerous, and that is a great disservice to oneself. And because once symptoms occur, like we all know, the downward trend is very, very fast. From experience, those of us practicing hepatology will know that for most persons who develop this virus in chronic hepatitis B, like I said, they remain asymptomatic. And once they begin to manifest symptoms, the symptom is either because a malignancy has started forming somewhere, the liver has developed malignant cells, or because the liver has failed. The liver is such an organ that it has a large capacity to endure and regenerate. And so the liver does not manifest symptoms of liver dysfunction, especially if the assault is chronic and, and slowly progressive, until about 80–90% of the liver is completely damaged. And so when you wait for symptoms to occur, it's usually very late. I think I failed to mention something about chronic hepatitis C. That hepatitis C is one virus now that once the antibody is positive, the next thing is to screen for the RNA. Unfortunately, part of the handicap we have is that I think a lot of people still don't know about hepatitis C virus infection. Not too long ago, I lost a friend from hepatitis C virus infection. What happened? She told me she screens herself every year for hepatitis B. And for some reason, herself and those who screen her never screened for hepatitis C until she came down with liver failure. And by the time, she developed all the complications of liver failure, by the time she was HCV positive, and unfortunately, we lost her to that. And I think I still said that a number of times, where people at the peripheral just screen for hepatitis B and forget to screen about hepatitis C. And sometimes recently I saw a patient who said because they didn't have enough money, they told them to just screen for B. The B turned out positive. They were pressing if they could get a discount to screen for C. And the healthcare provider told them not to worry, just go and treat the one you have already. Don't bother about that one. So that sort of misinformation still exists. C is as dangerous as B, if not more dangerous in a certain way, because irrespective of the time hepatitis C virus is acquired, 80% will progress to chronic hepatitis. And so that is one of the chronic viral infections that treatment is indicated even in the acute phase. Antiviral therapy could be warranted once they have any detectable HCV RNA. And good for us these days, it's curable. So why waste time?
You wonderful answers. Please, for pregnant women, is there a risk of a pregnant woman passing this virus to their unborn babies? And if there is a risk, how should a pregnant woman follow up from the time she was, if she didn't do any of these things and unfortunately she was diagnosed when she was during pregnancy? What should the person do?
Okay, thank you very much. I think that's where they expanded the directives on the expanded WHO criteria or guidelines for treatment. I think is really quite encompassing now, and it's quite interesting. It enables us to accommodate a lot more persons who are surface antigen positive, and especially for those of us in this part of the world. The recommendation is that every pregnant woman must be screened for hepatitis B and C viral infection. Now, if they have hepatitis, if the surface antigen is positive, now the guideline doesn't bother about what is the viral load, which was what was obtainable before. For pregnant women, the treatment guidelines was the same as for normal healthy persons. But now, once they are surface antigen positive, just wait till their second trimester if they are not on treatment already. Those drugs are very safe, even in pregnancy. So for persons who are already on treatment, they continue treatment. Even when they get pregnant, you don't stop the treatment. But for persons who are not already treatment, and then during antenatal visit, they are found to be surface antigen positive, wait till the second trimester, around 26 weeks of pregnancy, 28 weeks, commence on antiviral therapy, and they should stay on antiviral therapy through delivery and breastfeeding, and then reevaluate them on their own capacity for need to continue treatment. If they have need to continue treatment, then continue treatment. If they don't have any indication to continue treatment, then treatment can be stopped for them. So I think it makes it really, it's a whole lot easier now, even for those at the primary healthcare or secondary healthcare level, to start those patients on antiviral therapy without waiting till they do a viral load, they do a liver function test, they go and see the specialist. Based on this new guideline, that is really no longer necessary. So a whole lot more mother-to-child transmission, horizontal transmission during breastfeeding, can be stopped.
Thank you. Somebody, a participant is asking a question. Is their NGO working on getting free medication for hepatitis B, hepatitis C to Nigerians so that they can, now that the cost of these medications, are there NGOs that are doing that you know?
Sincerely, there are none that I know. Part of the problem is that Nigerians NGO, most NGOs in Nigeria, since I don't know whether they are NGOs or profit-making ventures, I don't know. But they are non working with us. Maybe if they are doing something independently, I haven't heard of any. But there are none working with SOGIN or with the gastroenterologist in Nigeria that we know of. There was a time some free medications was brought in from Egypt to SOGIN, but it was very close to expiration, and so it didn't really get to benefit most persons before it expired. So it didn't get to be properly distributed before they expired. So to the best of my knowledge, no. The NGOs working under the HIV medications, persons who have co-infection, HIV, hepatitis B co-infection, those are the ones that access free care because they just key into the HIV program. The drugs have been formulated in such a way that they cover for hepatitis now. Every first-line medication contains tenofovir. However, for those who have singular infection, they still have to pay out of pocket to get their medications.
Thank you. We're enjoying your discussion, so we have many more questions. So somebody asked a question: will you treat acute hepatitis C infection with antibody positive test?
No, hepatitis C must only be treated based on HCV RNA detection because the antibody, anti-HCV, it's an antibody. It just shows they've been previously exposed. For most of them, we found that even though they're antibody positive, they don't have a detectable RNA, and so they don't qualify for treatment. I mean, the virus is not there. There's nothing to treat. So you do not treat hepatitis B based on the antibody assay. You must do the HCV RNA and treat only when they are detectable. Any detectable HCV RNA qualifies for treatment. And treatment, it's curable. Treatment is finite. It has a finite duration. The only challenge is that it's still expensive, even with the use of the generic medications. It's still a bit expensive. Not as expensive as it used to be, but I think it's still a bit expensive for most, for the average Nigerian. And so part of why I highlighted it in this discussion is that still efforts should be made to make the DAAs available, either at very subsidized price or free medications for persons with HCV infection.
Thank you. And somebody is asking, what is the treatment modality for pregnant women with comorbidities of HIV and HBV? I think you have answered part of the question, but the person wants to know HIV and hepatitis B. What is the treatment like?
Well, the standard rule is still to test and treat. So once they have HIV infection, test and treat applies. So, but like I said, if they haven't been on any medication before and they are healthy enough, you may just still wait till they are off the first trimester and then start them on medication which they take for life. For such persons with co-infection, treatment is already for life from day one, irrespective of any other parameter.
Thank you. One participant, Steve Obano, is asking the question: what is your experience with? I know you have done a lot of work in this place where he's asking. What is your experience with hepatitis Delta co-infection in Nigeria?
Well, really, I have very little experience with that. I haven't actually seen a person with HDV co-infection. And we did a bit of a study then in Calabar. I think we found 5 persons, a prevalence of 1 point something, which is quite low. Unfortunately, it was a community-based study. It was difficult to go follow those persons up. Someone did a study sometime again in Port Harcourt, and there was no co-infection. But we encourage ourselves to be on the outlook for it, especially persons who seem to have very severe, manifestation, very severe symptoms of the hepatitis, or persons who already, who are rapidly decompensating. it may be necessary to screen to see if they have the Delta virus. Again, part of the handicap is that the reagents or facilities to screen is not routinely available. To assay HBV, it's still expensive, and HCV, even though, the awareness, people assay for it more frequently. Now, D, it's a whole lot more expensive to assay. So high index of suspicion goes a long way to mitigate that. But again, if D depends on B, so if we put all the facilities in place to eliminate B and inactivate B, I think we'll end up doing a whole lot of harm to D too. And it's not going to be able to become a big problem.
Thank you. We have less than 8 minutes to go. Somebody's asking, do you routinely diagnose hepatitis E in adults?
Do we routinely diagnose it in adults?
Yeah, hepatitis E.
Yes. Unfortunately, no, we don't routinely screen for hepatitis E. We don't at all. Even A, we don't routinely screen for it. Luckily for us, it is self-limiting, except in pregnant women. Pregnant women who have features of acute viral hepatitis, we may go out of our way to look for how to, make that diagnosis, screen for it. Otherwise, it's not something we routinely do. And luckily for us, because they are self-limiting and they rarely cause fulminant hepatic failure, we don't routinely screen for them. Again, in settings of fulminant hepatic failure, one may be, be motivated to find a place to screen for it. It's not something that is routinely done.
Yeah. Another question is asking, is there any indication for treatment of acute hepatitis B?
Except in the settings of fulminant hepatic failure, acute hepatitis B is not routinely treated. Like we said, for most persons, it's self-limiting. Persons who acquire it as adults, 90%, 95% of them will go ahead to clear it. It doesn't progress to chronic infection. So it has to be on a case-by-case basis that you go ahead. You must, for most times, we give the person time to recover, see if they can recover. But of course, if there's evidence of severe and rapid, damage of hepatocytes and the setting of acute severe hepatitis, we will be going to likely initiate antiviral therapy if it is safe to do that.
Someone is asking a question. I think when you were presenting, you said something about that. Say, can one have both hepatitis B and C at the same time?
Oh, yes, one can have both hepatitis C and B at the same time. I think we tried to do a study on that again in the south part of the country. It wasn't very common, about 1-point-something prevalence of that. Some studies was also done in the NEW. It wasn't very common. For such persons, you must assay the viral DNA for both viruses and find the one that is driving the infection. Most of the time, it's either B or C that is driving, not both of them at the same time. And so you treat that one first, especially now that C is curative. So if you have hepatitis B and C infection, you do the HCV RNA assay. There is any detectable HCV RNA, treat and achieve cure, then go ahead and maintain suppression of the hepatitis B virus with the appropriate medication. Again, lifelong, really, under that circumstance.
Thank you. This question is important because we have mixed audience here. We have the participants we have a diverse participants here. So the next question is concerning the mode of transmission of hepatitis B. So kindly talk about the minimum level of contact needed for a successful transmission. For example, persons come in contact with another person with hepatitis B who is profusely sweating. At what viral level can we say transmission can occur? So that's what this participant wants to know about. Yeah.
Okay. The good thing, I think, for all the studies that have been done, sweat has not been identified as one of the body fluids for this transmission. Um, Saliva, vaginal, maybe because of the skin. Most sweating will come through the skin, and the skin forms a very protective barrier. So for sweat, that's really, it hasn't been identified as a body fluid for transmission. And so I think you should worry less. And that is why we don't encourage persons with hepatitis B. You could share, things that are not invasive personal materials with them, share the same toilet, share the same bucket. And that's part of why we do this awareness, to reduce stigmatization. Shaking hands with someone with hepatitis B, giving them a hug, does not transmit the virus. Even sharing the same bed does not transmit the virus. What will transmit the virus is, it's a deep kissing where saliva is involved. And then especially if there are ulcers in the mouth, okay? Anal penetration, vaginal penetration. And then if there is a cut, and that's why we keep emphasizing sharps. Don't share sharp objects, razor blade, nail cutters, hair cutters, anything that has a sharp that could cause some minor abrasion to the skin or wherever it's used. And then the other important thing, we talked about communal use of toothbrush. Why is that very important? Because most times you're brushing, there's some minor injury to the gum that you may not consider important, and then someone else uses it. We know that hepatitis B virus is a very tenacious virus. Some studies have shown that it can stay on a surface for 7 days, and is 100 times more infectious than HIV. So it's a very, very tenacious virus, dogged virus. On its surface, it can be infectious. Once this, an open skin or mucous membrane is exposed to it. I use the word open skin that has an abrasion or a cut. Otherwise, it doesn't penetrate the intact skin. And so maybe that is why sweating has not been included as a body fluid for exposure. Now, transmission of the virus is dependent on the viral level. The higher the number of virus, the more likely the transmission. And unfortunately for us, persons with the highest number of viruses are those who are not manifesting any symptoms. Persons we used to say in the immunotolerant phase. They're not yet manifesting, they have the highest, so you don't even know when you get this. And so that's why vaccination is really very important. Just screen and get vaccinated, and the protection is lifelong.
Thank you. Another participant is asking, how should we counsel a chronic hepatitis patient who wants to get pregnant? Any safe viral load before they should be advised to get pregnant?
Okay, the good thing is that hepatitis B virus is not transmitted to the child in utero, and it doesn't prevent the mother from getting pregnant. And so I don't really think someone who is hepatitis B surface antigen positive, irrespective of their viral load, should not be discouraged from getting pregnant. I've seen persons who go for IVF. Once they are surface antigen positive, some doctors will not want to touch them until the surface antigen disappears. And you have to keep advice. Look, this doesn't affect your fertility. Just get pregnant. Come during the second trimester. We start you on treatments to prevent transmission to your baby during birth, after birth, during breastfeeding, not while the child is in utero. And so I hope I've addressed that. It shouldn't,
yes, you have.
persons with hepatitis should not be discouraged unless they have manifestations. Someone maybe they have decompensated, they have symptoms of liver failure, or someone with hepatitis wants to undergo hormone therapy to get pregnant. Studies have shown that those hormones accelerate growth, hepatocyte growth and all that, and also accelerates viral growth and multiplication. So for those persons, it is essential to start them on treatment before you expose them to hormonal therapy.
Yeah, so there are many questions that we cannot exhaust Participants are enjoying your presentation, and some are hailing, some are asking questions. I don't know, that we'll take like 3 or 4 more, and then we'll stop.
But we can still have for the next 8 minutes. We can go to 3:10 because this is a very interesting topic. So please, let's
Yes.
go.
Dr. Lancia, you're on my side.
Prof, it's been a long time. We'll have to enjoy this, Prof. Please bear with us. Thank you.
Yeah. So another question is, what should one who still need to have a child and the opposite sex is free from hepatitis B? And I said, what should I do? Someone wants to have a child, maybe it's hepatitis B positive and the opposite sex is free from hepatitis B. But I think you have addressed part of it, just for emphasis. You addressed it in the discussion.
Yeah, for those where you have mismatch among couples, one is positive, one is negative. The standard advice is to use barrier methods of contraception until the other partner who is negative has completed their vaccination. Once they complete their vaccination, there's no problem. So I think that's what I need to add to that. Use barrier contraception until the negative partner has completed the full course of hepatitis and vaccination. And so the positive person, while they are being evaluated for treatment, if they meet treatment criteria and all that, the other person starts vaccination while barrier methods of contraception is used.
Thank you. One participant thinks that many people are not aware of hepatitis B. They don't even know what is hepatitis B when you go for outreach. So Dr. Han is asking, how can we increase awareness of the prevalence of hepatitis B and C in our environment? Part of what we are doing now is one of them. We need to know what more can we do? That's his question.
Like I said, the problem is really in the rural areas. We as health professionals, as an educators, should be able to organize more of these discussions in the rural communities. It is good that we have created awareness in urban centers, in the tertiary hospitals. This is the time to move away and relate with primary healthcare centers in rural communities. When we did a statewide screening in Cross River State some years back, exactly what you said is very correct. Most people, even healthcare providers in rural communities, are not aware that hepatitis B or even C is a problem. And so they don't take it seriously. And that is where most persons that develop new infection, that is where they are coming from. They continue to form infectious pool. When they leave the rural community, come into the city for one thing or the other, they form a pool for new infections to happen. So I think that is really what we need to do more, to extend the activities to rural communities, get them involved, get the primary healthcare in those places involved, get the health policy makers involved, and see how they can support the program to provide sensitization in rural communities, in local languages, in the local dialect. I think that will go a long way. And I think that is what more we need to do.
Thank you, Chief. During my posting somewhere in Lagos many years ago, one woman came to the hospital and she was crying that the husband sent her back because she was diagnosed with hepatitis B. What would be your counsel to many people are here now, those are health workers, those are not health workers? What will be your counsel to these people? I mean, this video we're going to go everywhere in the world. People are going to be listening and playing it. These men that send their wives back, or women that run away because the husband think it was that man told the wife to go and get the man that gave her hepatitis B. What will be your advice to this people?
Yeah, well, it's always a problem for patients, and they keep asking the same question. It's a very common scenario that you see, and it's very sad. It could be both ways. I've known women who were eager to also leave their husbands because they found they were hepatitis B surface antigen positive. And I keep telling them, especially when they come in, they're asymptomatic. They never knew, they had never had any symptom referable to liver disease, and they went for a screening and they just found they were positive. We keep trying to let them know that they may have acquired this. In fact, more than 90%, 100%, that they acquired those things as children. It wasn't because of what they did or what they didn't do. And that is why hepatitis is now part of the expanded program on immunization. Most people with chronic hepatitis acquire it as children, playing with other children, sharing meat, sharing sweets, sharing whatever children share as or even from their relatives, older relatives. We all know that in the typical African community, you want to give a child meat, you bite it first, mix it very well, and then give it to the child. Even an aunt will do the same thing. So most people get it as children. It wasn't because of what they did and what they didn't do. So most times I invite the couple and put them through, educate them. And I could say in 70%, 80%, it's successful. Most of them calm down and, reconcile and begin to find solutions together. Unless for people who are already suspicious of their partner or are just looking for a reason to leave their partner. Otherwise, I think proper education, make them understand that there's no immediate problem, screen the negative partner, commence them on vaccination, they get a vaccination while the positive partner is assessed for treatment. I think most times with proper education, they calm down.
Thank you. Because of our time, we will be winding up here. Prof, what will be your final comment or final word you have for our people this year as we mark World Hepatitis Day? What will be your final word to the participants or those that will be listening to you?
Okay, my final word once again is to thank you, Dr. Varistus. Thank Dr. Lassie and your MD, Dr. Kenechukwu, for this opportunity to be here and to share in this month's meeting. And then for those living with hepatitis, to know that there is no reason to feel stigmatized. It's just like any other viral infection. Someone is unlucky to be exposed to. And luckily for us now, there are medications one can take. Like I said, when I started this, it was only interferon that was available for treatment. Now there are very good medications, relatively affordable that you can take. There's a possibility that, especially when you come asymptomatic, don't be ashamed, don't be shy. The best service a positive person can do to the community is to let the relatives know, see, I'm positive, go and screen yourself so that if they don't have it, because it's likely the person was exposed to the same risk factor with the relatives while growing up. They screen and get vaccinated. And for those who are positive, no need to feel stigmatized. There are things that can be done. Yes, even though treatment is for prolonged periods of time, the medications are relatively very safe, and you take them conveniently just once a day, and they're relatively affordable. And for hepatitis C, it is curable. Yes, a bit expensive, but it's curable. So everybody should get screened. Pass on the message, pass on to your friend passes on to another person and to another person. What we call contact tracing. Let's be the contact. Now that we've heard about it, we can, promise ourselves that we're going to tell the next 10 persons we see, and each of those persons tell another 10 persons, and like that. And it will continue, the awareness will continue to improve. It wasn't like this 10 years ago. We've made some progress. It's just that we're not where we're supposed to be. So we encourage us to not get tired, to keep talking about it, keep encouraging one another, and hopefully someday, maybe not 2030, we'll get to eliminate hepatitis B and C in our communities. Thank you.
Thank you, Prof. Okonkwo. So somebody made a lot of comments here. Someone said Prof is stuffed because I'm proud to introduce them, introduce you now to people that this is the mentor that trained me, this person that trained me, so you understand when she's moving this kind of stuff, the benefit I had training under her. So she's so committed professor that can stand in the word. as a registrar, you'll be tired. She can stand from morning till evening. She's not tired. I'll hand over to Dr.
Okay.
Lasha and Dr. Kenneth.
I'm going to. Thank you very much.
Yeah, no further comments from me except to say thank you so much to Professor. And we've really enjoyed today's delivery. It was a masterclass. I would like to invite our medical director, Kenneth, to make his comments.
Prof, again, just to echo what everyone has said, want to thank you for this masterclass. And we know how much hepatitis B and C are a burden for us in Nigeria. About 20 million people with chronic infection. And this is something that we can only improve if we talk more about it, sensitize, try to educate. And as GI doctors, try to influence the government as well through SOGIN. So thank you so much. Like, they've all said you were a teacher to me as well in medical school. I know that, we all can't forget how committed you have always been to not just to educate, but to educate patiently and supportively. This has always been how you've carried out your teaching, and we are very grateful for your time. So thank you.
Thank you very much. Thank you.
All right. So we just to say thank you as well to our participants for the very robust discussions we've had, the questions that are quite stimulating, and to every other person who couldn't make comments or ask questions. Thank you so much. And with this, we'll bring today's webinar to a close. And thank you, Professor. Let's all keep safe and continue to speak about hepatitis in any way we can. Thank you so much. And let's have a wonderful day.